Chapter 24, the trauma overview. So for the next week or so, maybe not quite a week, maybe the rest of this week, we're going to see some stuff. There's going to be pictures. There's all sorts of things that we're going to get a look at to kind of show us some of the injuries we're going to talk about. And I try to remember to warn, but I don't always look ahead. So just know that when we get into things like soft tissue injuries and orthopedic injuries and that kind of stuff, that it is quite possible to see some pretty gnarly pictures.
Tommy?
So what we're talking, yeah, somebody had a question?
Yeah, I do. Quick question. Is it true our midterm is this week?
You know what? I will look the first time I send you guys on break and get back to you. It might be. It should be on the syllabus.
All right, cool.
All right. So when we're talking about trauma, we are actually talking about energy, kinetic energy, and really sort of force being applied to the body. Because at the end of the day, that's what traumatic injuries are. Traumatic injuries are forces being applied to the body that the body either does or does not withstand very well. Mechanism of injury, mechanism is easy for me to say at 8 o'clock this morning. Mechanism of injury is how the person was hurt. It could be motor vehicle collision, could be fall, could be gunshot wound, could be stabbing. It is what happened to the person. When we start to form our general impression and get into our scene size up, we're always thinking mechanism of injury versus nature of illness, because that's going to tell us which path to head down as far as how we're going to assess this patient. Trauma is pretty straightforward. It is pretty easy to figure out. A person fall down, go boom. Mechanism of injury was fall and gravity helping them to the floor. Trying to predict sort of the kinetics and the way that energy of them falling is transferred into the body is a little bit more involved. Kinetics of trauma is them actually analyzing mechanism of injury to help predict injury patterns, injury extent, and really for us to figure out how much of this patient is going to be injured. When we talk kinetics of trauma and mechanism of injury, obviously the higher amount of force applied to a person is going to be a much more significant mechanism of injury. It's going to increase our index of suspicion that even though we may not visualize injury, we may not actually physically be able to see anything broken or bent or crushed or bleeding, that it is very likely that something is. We don't have x-ray vision. There's no way for us to actually determine whether something, within reason anyway, is actually broken most of the time or internally bleeding most of the time. We have to think about how much energy and how much force was applied to that one area of that patient, and is it significant enough as far as energy transfer to the person to injure the structures underneath. When someone is in a vehicle, I've mentioned this before briefly, and we're going to talk about it a little bit more today, but let's say someone is in a vehicle. The mass of the vehicle and the velocity of the vehicle is going to tell us just how much kinetic energy there is. That's going to, and this is, like I said, armchair physics. This is not going to be something they're going to expect you to be able to figure out how much energy is applied to a person. But when we think about how heavy something is and how fast something is moving, it's going to tell us the velocity that that person inside that vehicle is moving is the same velocity that the vehicle itself is moving. When you are in a car and you're propelling yourself down one of Massachusetts' wonderful highways at 75, 80 miles an hour and people are blazing by you like you're not even moving, your person is also moving that 80 miles an hour. The amount of energy that it is possible that that car and that speed will transfer into you if you hit something and come to a rapid and sudden deceleration is going to be the same force that is applied to that car. So when you're moving forward, this law of inertia, this is about the easiest, most simplest way I can break this down. The law of inertia is going to tell you that a body at rest will stay at rest until something acts upon it. The part that we're looking at now is a body in motion will stay in motion until something acts upon it, and that's this car hitting a tree. So the person inside this vehicle is still moving forward at whatever speed this car was until that person is stopped by something. Now, hopefully, their deceleration is assisted by a seatbelt and an airbag and, you know, all of the vehicle restraint safety systems that are meant to slow down a person rather than have them come to a brief sort of interlude with, you know, the windshield or winding up outside the vehicle in an ejection. All of those restraint systems, all they're supposed to do is ease that sudden deceleration so that your body is not absorbing all of the force. When we did the shock case study and we were talking about a damaged steering wheel, that steering wheel got damaged because that patient hit that steering wheel chest first, because that's normally how that happens, and was probably going whatever the roadway speed was when he hit that steering wheel. No seatbelt, no airbag, chest into the steering wheel gets deformed. That means that patient was moving forward 40 or so miles an hour when they hit that steering wheel, and they hit it with arguably one of the more important spots on their body, and hit it hard enough to not only damage the steering wheel, but also, index of suspicion wise, we can say damage structures underneath. Then we couple that with our ability to assess a patient. And right in the middle of the primary assessment, when we're doing our airway, breathing, and circulation, and we're assessing and we're treating those problems, we make our transport decision at the end, but that skin color, temperature, condition, and our patient's changes in the level of consciousness told us right away that he was injured before the patient probably knew they were injured, before any real significant outward signs told us anything, because we identified shock. And our big thing for trauma, and one of the most important things I can drive home to you, is we can't really make a very big distinction on, oh yes, this is definitely injured. Oh yes, this is definitely out of place. This is definitely wrong. We make our treatment decisions for a trauma patient, first of all, very rapidly, because time is the best thing we can do for a trauma patient. But we make our treatment decisions based on what could be wrong. I don't need to be able to actually physically verify that, yes, this is broken, this is out of place, this is twisted or bent or angled. It doesn't make any difference. It makes not one bit of difference. Who do you think fixes traumatic injuries, like actual fixes of a significant trauma patient?
Probably surgeons or doctors.
So surgeons is really where it's at. Trauma is a disease of surgical intervention. When we have a significantly injured trauma patient, surgery is going to be what they require. I saw in the chat room somebody said a medic, and realistically, medics kill more trauma patients most of the time than they save. Surgeons are where it's at, because at the end of the day, even medics aren't going to be doing, you know, roadside trauma surgery. They're not going to be doing internal and external fixations and putting rods and pins and broken bones and stopping internal bleeds. This patient, to have the best chance of survival if they're a significantly injured trauma patient, needs to be on an OR table less than 1 hour from injury. And the way we support that is by less than 10 minutes on scene. That's called the Platinum 10 minutes and the Golden Hour. The Platinum 10 minutes means from the minute I get out of my truck I need to be on and off scene and back in my truck and leaving in less than 10 minutes, unless there is some pretty significant extenuating circumstances, like a patient's trapped, or we have trouble accessing, or we're out in the woods and it takes a long time to get them back to the ambulance. Certain things we can't overcome as far as on and off scene. But we'll talk about helicopter EMS towards the end of this lecture and how they can really benefit a patient who has those kind of injuries and those kind of access problems. But the platinum 10 minutes in the golden hour is where we want to be with trauma patient. When we talk about energy, energy travels in straight lines unless it's met by some kind of interference. After that interference is met, it changes form, but still travels in straight lines. So when we see a patient who, say, has jumped off of a building and they land on their feet, oftentimes we don't find a whole lot of mangling type injuries to those feet, or maybe not even to those lower extremities. That energy traveling in straight lines up through their person will cause burst fractures in their lumbar vertebrae. It'll cause hip and pelvic fractures from all of that getting up to the weakest point, meeting at a joint and blowing something up. So don't always be in the habit of looking right where the injury happened. When we look at a significant mechanism of injury in a significantly injured trauma patient, we need to get in the habit of examining everything. Because what does the human body do in relation to stress? What's one of the big things we've talked about over and over and over again, that when under stress, the human body does this?
You mean
Shock?
like the fight or
So shock and the fight or flight response. The fight or flight response, when the body is placed under some sort of stressor, when something happens to the human person, the body's first reaction to that is a release of epinephrine. And that epinephrine will cause injuries that should be very, very painful to not be painful at all. It'll cause injuries that should be, quote, distracting to our patient. I'm talking like angulated fractures and open fractures and things like that, things that you look at and go, oh, holy smoke, that's awful, to be of little or no consequence to that patient's mind whatsoever. So when we have a significant mechanism of injury in the trauma assessment that we're going to talk about a little bit later on in lecture here, is a very detailed, very thorough, but quick head to toe assessment. Because remember, we're against the clock. We have a 10-minute window to get done all of the things we need to get done and get that patient moving. So we need to inspect, palpate, auscultate, touch, poke, prod, look at, do whatever we need to do to this entire person, based on the fact that they have tons of epinephrine coursing through their body. They have been exposed to something that would be significantly painful and may cause them to go into shock. And once they get to those beginning stages of shock and all that epi is running around inside of them and they are trying to compensate, all the usual things that a patient who isn't as significantly injured, that they would tell us, our significant mechanism of injury trauma patient probably doesn't have the mental wherewithal to do that. When we talk about just isolated traumatic injuries, so think like a simple wrist fracture. Anybody out there ever broken a bone?
yes?
All right. What do you remember about that?
It hurts a lot. Gets
There
super
you go.
swollen.
Perfect. It hurts a lot. It's swollen. You probably didn't want to move it. You probably didn't want to use it. You were probably doing some self-splinting by kind of keeping it pinned up tight close to your body. Our patient who doesn't have necessarily this huge, crazy traumatic event going on is likely to be some form of altered. They're likely to not be a whole lot of help in telling us what hurts, where it hurts, how it hurts, all of those questions. So it's on us to figure it out. Our patient who's a simple trauma patient with just an isolated mechanism of injury to, a wrist, a forearm, something like that, they are going to tell us and anyone nearby all about it because it hurts. They don't want to move it. They don't want to do this. They don't want to do that. They're conscious, they're alert, they're oriented, they're able to help in their care. And we get better sort of person-to-person information from them at that point. Your significant mechanism of injury trauma patient is likely to have way more involved concerns and not really be altogether that much assistance to us. When force is applied to the human body, we'll talk motor vehicle collision here for just another second, but this really can be relative to any type of collision whatsoever. I have a friend whose kid recently fell off of his bike and had all of these same exact things happen to him. First, you have the vehicle collision, which transfers energy to the body. Then you have the body colliding with something, which transfers energy to the body. And then you have the organs colliding with the internal structures of the body, which transfers even more energy to those already injured, already possibly damaged structures. And that's just the initial, because the way trauma works is coup counter coup. So the coup is when you lurch forward in a crash or in a fall. It's when you move forward. But then generally what happens? Let's look at this picture because the arrows give it away. We have the body moving this way, right? Then it's going to hit the steering wheel. The organs are going to hit. And then what's going to happen after this patient hits the steering wheel?
Most likely their ribs are going to be either fractured or broken.
Yeah, so we're going to have some pretty significant injury, probably to the rib cage, maybe the heart, the lungs, the liver, the diaphragm. Yeah, absolutely. But are they going to stay against that steering wheel?
No, they're probably going to bounce back.
Yeah, because that 40 miles an hour they were traveling is still pushing backwards. And they're going to crash again into the inside of the vehicle, and then the body's going to hit something, and then the organs are going to hit something. That's that counter clue when the body gets blown backwards as well. So they have all those three collisions going forward, and then when they get pushed backwards and hit again, they have three more collisions. So every single time that a significant traumatic event such as this happens, there is multiple impacts, multiple collisions of the body against things, multiple collisions of the body against itself, multiple internal collisions of the organs striking things because they're not anchored. And we have multiple spots and places that this can happen, and multiple injuries that can be as a result of it. So when we talk high index of suspicion, get used to hearing those words, get used to thinking in those terms, right? High index of suspicion that our patient is going to be significantly injured from a motor vehicle collision is death of another occupant, a patient who is unresponsive or altered, if there is intrusion of the outside of the car of 12 inches or more, or if they've been ejected from the vehicle. Someone who gets ejected from a vehicle is like 80% more likely to die than someone who stays inside the vehicle. Inside the vehicle is where you're meant to be. So let's take a look at these a little bit here and there. Death of another occupant. Why would that sort of tickle your spidey sense and make you think that this patient could be pretty well messed up?
The
I don't
damage
need
Point of
that
technical
impact,
correct
done.
answers. I just need thoughts.
like the impact of when the car hit and the other one died. So it had to be strong enough that the driver could have gotten, you know?
That's spot on what I was looking for. All of the people inside of that vehicle were exposed to the same amount of force. Why is one dead and one still alive? That's the first question you should think of when somebody is obviously deceased from a motor vehicle collision. Why is one not? Because they both had the same amount of everything applied to them. What about the next one down? Unresponsive or altered. Why is that sort of something that should make you really kind of cautious with this patient?
Because they're unresponsive and altered. We don't know how hard the car hit or that force. Unresponsive, clearly something happened that they're knocked the heck out. Altered, how hard did they hit their head that they're whooping, like, you know?
Yeah, and to be honest with you, after a trauma, one of the earliest signs that there has been a brain injury of some form or another is going to be either unresponsive or altered mental status. And most traumatic events where the patient survives the initial but winds up passing away anyhow is a result of some sort of brain trauma. Almost all traumatic deaths are going to revolve around some form of trauma to the patient's actual brain. What about the next one? Intrusion. What does that even mean?
Well, it could mean that the front half of the car has pushed in, but like there's also stuff in that front half of the car that could have been pushed in towards the person as well.
You got it. It means that the outside of this car has been pushed 12 inches to the inside of this car, because the way you would describe that is spot on. Anything that gets pushed back 12 inches, the next thing in line is going to get pushed back 12 inches, and the next thing in line is going to get pushed back 12 inches. That's how things like dashboards and engines wind up inside of passenger compartments of vehicles. You know, years and years ago, you had these giant land barge cars that were made out of steel, and everybody thought, I'm surrounded by all this metal, I'm going to be in good shape if I ever get into an accident. And you know what? They couldn't have been any more wrong if they tried, because those giant steel land barges didn't absorb any energy. The way they make and manufacture cars today, the car is actually meant to take all of the impact. You will show up to accidents in your career as EMS providers, and the car will look absolutely demolished. It'll be torn near to pieces. And the occupants that you'll be looking in the vehicle for, because you'll think there's no way anybody got out of this accident, will be out taking selfies and posting on Facebook and TikTok about the car accident they were just in. The vehicles will look like complete trash, and the patients will be just fine. You used to have like legitimate cases where engine blocks would wind up inside of passenger compartments with those old giant steel cars, because the energy just went right straight through it because of the way they were manufactured. And now things are a bit safer. So don't always base the amount of damage to the vehicle itself on how hurt this patient is going to be.
If it's pushing less than 12 inches, is it called something differently?
No, it's still intrusion. It's just the distance that we're talking about is what makes it, if a car is hit hard enough to push 12 inches of the outside into the inside of the car, that's a pretty significant amount of speed and amount of force taken to actually do that.
Yeah.
So let's look at some of our collisions here and some of our injury patterns that we can expect. Because remember, we're talking about energy, and energy does travel in straight lines. So we have here essentially pictures of all unrestrained drivers, because even in the bottom left corner, it shows a lap belt, but they are clearly not properly restrained. If you're wearing a seatbelt, the seatbelt will prevent most of all of these things from happening. You don't have that coup counter coup force. You don't have all of those impacts happening inside of the body, because the minute the seatbelt sensors go off and in an accident, they lock in place, and you don't get to get thrown around by gravity and by kinetic energy inside of this car. You are stuck to that seat like glue. But if we look at this patient right here in the upper right-hand corner, unrestrained, travels forward, hits the dashboard, and that dashboard doesn't just injure the knees and the front of the legs like you would expect it to, because those are the places that, got smashed into. We're going to have hip dislocations. We're likely to have pelvic injuries. We may have fractures to the hips or the pelvis, just because that force is going to find a way to dissipate itself through the body. Same thing can happen here with a frontal impact and no seatbelt again. Depending on how the patient is positioned in the seat and how the patient is actually sitting, they may come up and over the dashboard and wind up kissing the windshield, or they could wind up underneath the dashboard and any one of a million different other things as far as injury pattern can happen. So assessing everything on a trauma patient, especially a significantly injured trauma patient, is really the take-home message for all of this. Especially if your patient is altered, especially if your patient is unresponsive. We can't fix a lot of it, but if we find it, we give the hospital a much better jumping off point. If we, when we get into the assessment, we're going to talk about deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. We'll talk about a noise called crepitus, which is bone ends grating and grinding together underneath our patient's skin. Sure, we can find all of that. Not a whole lot we can do with all of that. But if we have our assessment done the way that it's laid out and hit all of our marks for that, the hospital is going to be much quicker at figuring out what needs to be done for this patient, getting them into an operating room, and providing the best chance that they're going to survive this significant traumatic event. Because a trauma patient is probably, and I don't mean, your average everyday broken finger. A significantly injured trauma patient is a real for life or death emergency. This patient is officially on the clock every second from when that injury happened. Looking at our rear end impacts, this is a bit of that coup counter coup that we talked about. A patient here in figure A is getting hit from behind. So the body snaps back, and then you can see the reflex of that, his body crashing forward because he's still being propelled. And that's that whiplash effect that we talk about with the neck. He's likely to have injuries more in the upper portions of his body. And you can see here, again, unrestrained. Remember, those seatbelts aren't just put there for decoration. And I heard a thing the other day when I was on my way to work, actually on the radio, that still as many as between 10 and 15% of people don't wear their seatbelt. You know, it wasn't enough when they just told you you should wear your seatbelt. It wasn't enough when they had cars that would actually, as soon as you shut the door, put the seatbelt on for you. Now it's not even enough that they have cars that are absolutely outlandishly obnoxious if you don't have your seatbelt on. I don't really get what the hang up is and what it's going to take to actually make people get the point. Maybe, I don't know, maybe actually being ejected from a vehicle or turned into a quadriplegic is, you know, what it takes. But personally speaking, I don't need to learn every lesson the hard way. These significant motor vehicle collisions, most of the injuries that come along with them can be avoidable, especially with the way vehicles are designed now. And, you know, maybe just by not driving like the streets of the Daytona 500, probably also a pretty decent idea. Now we're going to talk about a lateral impact. One of the things we have to think about when we talk lateral impact, you know, in a front end or a rear end collision, generally there's a lot of vehicle between the patient and whatever is hitting them. In a lateral impact, there's not so much. You have a door and next to nothing else. Most of the times in these significant lateral impact crashes, unless there are side curtain airbags and those kind of things, and then sometimes even if they are, the patient's head is what breaks the window. The patient's body gets pushed one way and the head comes and smashes right through the passenger side window. So now not only are they taking the force of the actual collision, but they're also sustaining a head injury, neck injury, and one of the biggest contributor to traumatic deaths is what again?
Shock.
Shock
And head injury.
and head injury.
Yeah, somebody busted their head. We can't fix that on the scene.
And the last little bit of vehicle collision that we're going to talk about is rollover. I've actually been involved in one of these. It was the wildest ride I have ever been on. Rollover collisions are a catch-all. First of all, there's some initial type impact that actually made this whole rollover bit happen. And from there on out, every single time, illustrated in this bottom picture here, that car comes to strike something else, there's more collision. Your body's going to hit something, something's going to hit your body. Now, if you were to look in the window of my car, it looks like I live in it. If I was involved in a rollover or rotational collision, all of the things that are inside of my car get turned into projectiles. So now not only am I crashing around and bumping around and hitting everything inside the car and everything inside the car is hitting me, I'm actually having stuff thrown at me as well because of all the crap that I have in my car. So I don't recommend this. This is not a whole lot of fun, but it is something to behold, that's for sure. Now let's think about velocity and force and all of that good, fun, happy stuff when it is applied by a motor vehicle to someone who is not in one. When we think about auto versus pedestrian, what hit the patient, what the patient was doing at the time, and how fast the car was moving, because remember, movement, how fast they're going in a forward direction is going to play a lot in how much energy they are actually hitting that patient with. Anyone who doesn't believe that, if you've ever, been just like bumped by somebody backing out of a spot in a parking lot versus actually been in any type of collision for real, and I'm even not talking auto versus pedestrian, I just mean think about the differences, right? If you're sitting in your car and somebody pulls into the spot behind you and just taps your bumper, not a whole bunch of damage, not a whole bunch of injury, probably not something that I would even bother going to my insurance company with. If somebody hits me out on Madison Street at 25, 30 miles an hour, way different scenario. The same thing goes for people. It all depends on how fast they were going. Now, does the book go into this whole common injury pattern thing for adults versus children? Anybody ever heard the term deer in headlights? And how when you're driving down the road and your headlights hit a deer, they just stop in the middle of the street and you wind up smushing them?
Yes.
Kids kind of do the exact same thing. When a kid sees a vehicle, then they're out in the street and they see a vehicle approaching, it's like they turn towards it and open themselves right up to be run over. Their brain just doesn't compute the, hey, this is dangerous, you need to start running. Instead, it's like they turn to look at it and they take the impact frontal, right on their anterior portion. Now, height of the vehicle is going to depend on what part of them gets hit. Did the vehicle try to stop or slow down, which will sink the nose and depend on which part of the child gets hit. But kids normally take the impact for an auto versus pedestrian face to face. They look right at it and get grilled. Adults, on the other hand, if you were ever crossing the street and saw somebody come wheeling around the corner, what would your first instinct to be and what would you do right away?
I mean, normally you would move, but I feel like that also depends on your fight or flight response because I've been hit walking down the street actually last summer when I was pregnant by this like crazy lady and I just froze. Like I couldn't really do anything. So I feel like depending on your fight or flight, you'll either stand there or you're gonna move out the way.
Yeah, I mean, and you're absolutely right because the body, that's the perfect example of when that response gets triggered, the brain does weird things, right? But for the most part, you're not going to turn towards it and look at it. You're going to have that moment of panic. Maybe you freeze up and maybe you still get hit and whatever was nearest to the car is what's going to get hit. Or
Right.
you're going to try and get out of the way. Most adults at that point cut and run and they wind up taking the impact on one side. So it's like a lateral impact on, one hip, upper portion of the lower extremity on the other, because they're trying to boogie themselves right out of the way when a car is coming at them. When we talk about seatbelts, they call this a hidden injury, right? Seatbelts and airbags for sure can do just about as much damage as they can do good, especially if you're not using them appropriately. A lap belt is meant to go across the bony prominences of your pelvic girdle and across your lap. It is not meant to go across the lower portion of your abdomen because all sorts of things that don't like that kind of force being applied to them live in this area right here. What are some of them? If you were palpating this left and right lower quadrant of your patient respectively, what are you feeling for
Your
in this
small
area?
intestine.
So I heard small intestines. What else? This is a female patient.
Your reproductive organs?
So yeah, reproductive, depending on where the lap belt's placed, we could start to have problems with our patient's uterus, our patient's bladder, our patient's, organs of reproduction. You're absolutely correct. And some people, for one reason or another, why and how, I don't even understand, but this is something that they measure, so it must be a thing. Wearing the shoulder strap without a lap belt is not going to hold you into the seat. So the upper portions of you are likely to get hung in that shoulder restraint. and the lower portions of you are going to try and scoot out the bottom, and these are people for sure that you would find tucked up underneath the dashboard and wedged in pretty good. You know, these are certain circumstances where extrication could be an issue. But now let's go back to our bottom picture and talk about an improperly worn lap belt, and we'll say maybe the lap belt was the only thing used on this patient because we don't see the bruising start to move up across her torso. What's the upper portion of her body going to do?
Wouldn't it like fling over the strap that's holding her laterally?
Yeah, so she's likely to smash against the windshield or the steering wheel or the dashboard. And what part of her person is going to be what meets those things?
Her chest, her shoulders,
Her face.
her face, yeah.
So all of these things, when used inappropriately, are much more likely to cause you injury than not. Airbags, you can expect if your patient has been involved in a collision and the frontal airbag goes off, they're probably likely to have some burns along the insides of their forearms. They're likely to even have facial fractures, broken nose, broken eye orbits, powder and contact burns on their face. But they were kept in their seat, in their vehicle, and didn't hit something like the steering wheel, the dashboard, or the windshield. So they hit something soft, they just hit it at a high rate of speed. When it talks about sort of improperly positioning yourself in a vehicle and having an airbag cause you injury, recently they have gone from hands being supposed to be at 10 and 2. Everybody drives with 2 hands, right? 10 and 2 on the steering wheel?
No.
Yeah, me neither. You know, most everybody, especially around New England, they got that one hand in the middle at noontime, right?
Yeah, that's what I'm doing right now.
And you're driving down the road and you hit something and your airbag goes off. What's going to be propelled into your face round about 200 miles an hour?
The airbag.
And your fist.
And my fist.
So the new suggestion about how to position your hands in a car that has frontal airbags is actually 9 and 3. So we want to be doing the bus driver as opposed to
9 and 3.
And if the airbag catches your hands or anything, it's likely to just blow them backwards as opposed to assaulting yourself or breaking your thumbs or really finishing you up good. When we talk about motorcycle collisions also are a bit of a mixed bag. How the rider was struck, what the rider hit, how fast everything was going. But let's have a brief look at this picture. Let's say we're walking towards, we're forming our general impression. Tell me something you notice right away. What's something that you didn't miss the minute you looked at this picture?
First thing I noticed, the motorcycle is pretty destroyed.
The motorcycle's pretty destroyed. So we're looking at the motorcycle, right? Look real nearby that motorcycle. By the tail lights.
blood.
There, yeah. Oh, blood.
Almost all of that fluid should have been inside of that person. As I'm approaching, I'm looking at this, and the blood smear starts over here and runs all the way off screen. Significantly injured?
Yeah.
If he's alive, likely in shock?
Yeah.
Anything and everything on this patient could be broken?
Hypovolemic shock.
What's
Yeah.
that?
I said hypovolemic shock because of the blood.
Yeah, I would say. And then let's look at this term right here, because we've talked about ejection a couple of times, and any motorcycle collision is technically an ejection. It is very infrequent that a vehicle of a couple of 1,000 pounds or more is going to strike a person on a motorcycle, and that person is going to remain on their motorcycle. So they are likely to be ejected from that vehicle. And then we have to start thinking about what happens next. So let's say your patient's ejected through the windshield. Their face hits the windshield, their head punches a hole, their body travels through the hole. Let's say they survive and they're still somehow miraculously doing well. What happens next?
If they survive, then they go, you gotta get them out of there.
No, I know what we're gonna do, but we're talking about strictly just the collision right now. So they somehow rocketed themselves through the windshield, and at this very given moment in time, they're still reasonably doing okay. After they clear the windshield, what's the next step in this whole progression?
They gotta hit the ground.
Yep, probably repeatedly, or they got to hit something else to stop them and slow them down. And all of those things are just another impact and just another injury. And sooner rather than later, they mount up to what may become insurmountable to this patient. Moving on through, we are now into the fall category. This is what I was talking about when people fall out of or jump out of a building, land flat on their feet. Sure, do we see some injury to the feet? Absolutely. A lot of times that calcaneus, that heel bone, is the first thing to go. But that energy is going to travel north and south. It is going to travel in a straight line. You are very likely to have significant injury much further up the patient than you probably thought you should, like in lumbar or even the bottom pieces of their thoracic spine. You're likely to have pelvic and hip fractures, maybe some knee fractures and dislocations. And it is all based on this gravity moving north and south, this impact and energy moving north and south. And all of that is just going right through this patient. So tell me something that you've already figured out about significant trauma patients. It's got to be a couple of things.
Well, we have to assume that they're gonna have spinal injuries.
Okay, I like it.
They're gonna be injured in more places than just one.
Yeah, and we're not likely to be able to just look at them and go, oh, well, that's got to be broken, that's got to be broken, that's got to be broken. If you can understand the fact that they are very, very likely to be injured in more than just one spot based on maybe how high they fell from, because a significant mechanism of injury for an adult patient is a fall of 20 feet or more. Significant mechanism of injury for a pediatric patient is only 3 times the patient's body height. So something as simple maybe as off of a bed or off of a couch, especially depending on how they fell, maybe what part of our patient hit the ground. So head first being a lot different than feet first, because all of that initial pressure, being applied to your person. We have hyperextension, hyperflexion, and compression are two of probably they're probably the 3 worst things that can happen to your cervical spine. Hyperextension, the neck does not do well being pushed backwards with a significant force. Hyperflexion, it doesn't bend forward any better. And any type of compression or distraction, so being pushed down from the top or being pulled out like in a hanging type injury, your neck just doesn't put up with that. You'll have compression injuries, you'll have flexion injuries that will absolutely cut right through the spinal cord. Your spinal cord and all of those nerves have the consistency inside of this column of overcooked spaghetti. So having these sharp, bony prominences come in contact with those nerves and with all of those nerve lines is going to have significant impact of your patient. And if we look, this is likely to be a pretty high cervical spine injury, right? Is the brain going to be able to send messages anymore? Well, the brain can send them, right? The brain's still intact. But are those messages going to get sent down through that spinal column?
No.
Is it going to get to all these other points out on the body?
Not likely.
So all of those neurogenic shock symptoms that we've talked about in a patient with paralysis or paresthesia and inability to feel or pins and needles after this type of an injury, they are likely to wind up with respiratory type problems, circulatory type problems, and a lot of it's based on the fact that all of those controls are right in that cervical spine, and this injury is likely to be life altering at best and possibly life ending. I have a friend who's actually been in a wheelchair for, I don't know, 30 some odd years, I think, because he dove into a pool, had this happen, and he's been a quadriplegic since. So this is legitimate bad news for your patient. All right, we've been at it almost an hour, and it sounds like I'm having trouble keeping everybody awake, so it's coffee time. We're going to take a break, and when we come back, we will get into low velocity injuries, and we're almost done with this, and we'll talk about how to actually assess this patient and get some good information. All right, so here we go. We're going to split the trauma hair even a little bit further now. Now we are going to talk about penetrating injuries. Penetrating injuries come in a couple of different flavors. First, we'll talk about low velocity injuries. Anytime we're talking about a penetrating injury and trauma, a low velocity injury, think of it as something that is person propelled. And what that means is this picture right here. That injury is caused by a low velocity injury. Someone stuck this gentleman in the leg with that knife. Generally speaking, these low velocity injuries are limited in the amount of damage that they've caused. Well, that's probably not a gentleman either. They are going to cause damage directly to what has been poked or prodded with the knife, the screwdriver, whatever else, whatever other object. And it is limited by the length of the object. So it's very infrequently that people get, attacked by a samurai and wind up skewered through and through. What we're talking about here is tissue damage to just a specific area that is stuck with the knife. One of the things that I can tell you about low velocity injuries, especially penetrating trauma with a person-driven weapon, is if somebody was mad at this individual to stab them one time, what it is very likely that has happened is they have stabbed them multiple times. So penetrating trauma, when we're talking edged weapons and things like that, is much more up close and personal. And normally, if you've only found one stab wound, you've probably missed one. This can be, nails, so workplace accidents, things like that, even glass. But it is generally the patient or someone that has caused this type of injury. When we get into medium and high velocity injuries, now we're talking ballistics. Now we are talking about trajectory. We are talking about energy being transferred not just into the tissue that it touches, but the tissue that surrounds it as well. That's called cavitation. If we look at these two injuries here, or if you've ever seen like a ballistics gelatin test where they shoot this jelly-like substance, and when they slow down the frame by frame of the video, you can see how the cavity inside of that gelatin is much bigger than the bullet. A small area of destruction is caused by typically your lower velocity projectile, because that pressure wave that travels through the tissue is smaller. We're not having as much of that energy dissipation. We're not having as much as that cavitation. When we talk things like rifles and really that's just about it. Now we're talking about a large area of cavitation. When a projectile is from a gun, it causes two types of injury. The bullet itself tunneling through the flesh causes a permanent wound cavity. That is the tissue that's destroyed and blown out the other end by the bullet. The temporary wound cavity is this cavitation that we're talking about, and it's all this damaged tissue and bone and muscle from the pressure of that bullet traveling through and damaging things. So on top of cavitation, we have bone fragments, we have bullet fragments going through and tearing things up. A gunshot wound to a patient, whether it's medium velocity or high velocity, is likely to be a bit of a catch as catch can. Bullets can hit bones and bounce and wind up in other parts of the body. Just because someone got shot doesn't mean that the bullet ever actually comes out. It may be stuck inside of your patient, bumping around into things, causing more damage, playing Pac-Man, and just really making an absolute mess of things. You may see lots of bleeding. You may see only a little bleeding. You may have an exit wound. You may not have an exit wound. Places when we look at on the body and we talk about gunshot wounds, we're going to try and figure out the significance of the structures underneath that are injured, because there's no way, realistically speaking, that a bullet travels through someone's chest and doesn't hit something important. Could be the lungs, could be the heart, could be the superior inferior vena cava, could be the aorta. We need to start thinking in terms of what's injured underneath. The head, obviously, is where the brain is kept. Chest, we're talking major vessels, big important organs. Abdomen, we're talking depending on whether it's high or low, whether it's along the midline, how significant the injury is. You know, the liver takes up a good portion of the upper quadrants of your abdominal cavity. What does the liver have a lot of?
Blood?
Blood. So if someone is shot in, say, the right upper quadrant, or just to the right side of their midline, it is very likely that even if we don't see blood spilling all over the ground from this injury, that this patient is going to have sustained some damage to their liver, and there could be significant internal bleeding from this external force, from this penetrating injury. When we talked coup, counter coup a little while ago, we talked motor vehicle collision and sort of the body in motion, staying in motion. Well, right now we're talking about a body at rest with a force applied to it. Blast injuries have multiple phases, and they are pretty straightforward, pretty common sense. The initial primary injury of a blast is a pressure wave that is made by the explosion actually happen. So you have something nearby, it explodes. The very first thing that happens to you is your body is exposed to this great big giant pressure wave that ruptures a lot of hollow internal organs, like your sinuses or your eardrums or even your intestines. That pressure wave actually will go through and make those rupture. After the primary injury occurs, we now have what's called secondary injury, resulting in the actual pieces of whatever it is that exploded now hitting and penetrating the human being. And what do you think this tertiary phase is? That pressure wave and all of that explosive force and all of this penetration is propelling the patient backwards. And the tertiary phase is when the patient comes to strike something else and winds up on the floor, embedded in the wall, blown out a window. This tertiary phase is when your patient comes to rest against something that is structural. So primary is pressure, secondary is penetration, tertiary is actually now coming into contact with something structural that stops you from getting blown backwards. Multi-system trauma is what we've been talking about almost this entire lecture. You know, I asked about broken bones out in the audience today, and we talked pretty simply about those single isolated injuries. And when we talk about single isolated injuries, do you think that I'd go start at my patient's head, you know, all right, I tripped, my head didn't hit the ground, my hands did. And I caught myself with my hands and I fractured one of my wrists. Do you think there's any need to go poking around your patient's head and chest and abdomen and on their pelvis and palpating, inspecting and auscultating and poking and prodding everywhere? So Jessica, it looks like you said that there is a need for that. So my patient has no loss of consciousness, has no head injury, and is able to speak to me and tell me what happened and complains of just this isolated injury.
Well, don't. I thought my mic isn't working. Can you hear me?
Yep.
Oh, don't we have to do like a rat in a trauma? We need to look really quick. I know we can see like they said that their hands or whatever, but just to double make sure that nothing else is happening that they don't feel.
Okay. And you know what? I won't argue that point with you. But what could I do rather than poking and prodding and making them more uncomfortable?
Talking to them, asking them.
Yeah. Are you sure nothing else is hurt? 90% of traumas are simple single injuries, one body system, fracture to the arm, soft tissue laceration with no gross hemorrhage. Most of our trauma patients are that straightforward. In a trauma patient who hasn't received a significant mechanism of injury, we do a very focused exam on. You know, if my patient says, I fell and whomped my head, sure, I'm going to do things that are a little different. But if we're talking simple lacerations, simple like individual broken bone, and my patient's story isn't, yes, I have this one obvious fracture from skiing into a tree or falling out of a 4th-story window, I'm going to do a bit of a different assessment. When we assess a multi-system trauma patient, we're going to assess the entire human. When we have these simple single injuries that the story makes sense and the presentation makes sense and your patient's not showing you signs and symptoms of shock, we're going to focus on the area involved and anything that touches it, much like with our focused assessment of a medical patient or that physical assessment of a medical patient. If your patient is a multi-system trauma, that means that they have multiple injuries involving more than one spot, involving more than one actual piece of them. Could be central nervous system, so we start to see altered mental status, some signs and symptoms of shock. Could be respiratory, could be heart related, so again, your signs and symptoms of shock. They could be complaining of GI pain, so their belly hurts after a significant motor vehicle collision. All right, well, now I know I have the gastrointestinal system, the urinary system, and a lot of blood. There's my multi-system trauma. You know, a patient who's just got that isolated injury is going to be treated a whole lot differently from our standpoint and from the hospital standpoint than someone who has these multiple injuries over multiple body parts and body systems, because your single simple fracture or your single simple laceration that only needs maybe a little bit of suturing to make it no longer a problem doesn't require the surgical intervention that our multi-system trauma patient does. The morbidity and mortality of a patient who has multi-system trauma is astronomical. Like the high incidence that in high likelihood that this patient is going to die is why we talk about these golden hours and this platinum 10 minutes. Because if we can get them alive to the operating theater in under an hour, it is very likely that this patient can overcome whatever this traumatic event was. So your piece of it is probably the most integral part. Because if you spend longer than that platinum 10 minutes, what are you actually taking time away from?
Their chances of survival.
Their chances of survival, and you're taking time off the surgeon's clock. And surgery is going to be what fixes this multi-system trauma with significant mechanism of injury and multiple body systems involved. So I mentioned earlier talking about, you know, difficulty in accessing the patient, difficulty in getting the patient to the ambulance and getting rolling, and how there are other things at play in us chewing through our 10 minutes. When we talk about helicopter EMS, brief overview of that is when transport time or accessing and moving the patient is going to eat up a lot of this patient's golden hour, it's probably time to get them to the trauma center quicker, wouldn't you think?
Yes.
And
Yes.
that's the time where we make the determination whether this patient needs to be med flighted or this patient needs to be ground transported. Because what I will tell you about helicopters is they land at level 1 trauma centers and drop patients off. They pick
Mhm.
up at all the rest of these places. So our trauma centers in our area are places like Mass General, Brigham, Boston Medical Center, Beth Israel, all of those big fancy Boston hospitals, Leahy Clinic out in Burlington. Those are all level 1 trauma centers. A level 1 trauma center, 7x24, 365, has all of the people on scene waiting for this patient to show up. The patient may not have even been created yet, but they are standing by waiting for a trauma alert to come into the hospital, and they can be operated on in the blink of an eye. They have imaging available, they have surgeons available, they have all the specialties available necessary to just walk into the emergency room and start sorting this patient out. A level 2 trauma center has those people available, but not necessarily always on scene. They can call them in and get them to the emergency room, to the operating theater, and they don't necessarily have all of the surgical capabilities. They can stabilize a much more significantly injured trauma patient, and then they transfer them to places like a level 1 trauma center. Those are your smaller hospitals, your places sort of out and around about the way. It is a huge financial undertaking for a hospital to become a level 1 trauma center, just because they always have to have a trauma surgeon on duty. They always have to have a radiologist. They have to have every specialty known to the world of medicine just kind of kicking around, waiting for this trauma patient to be brought in by ambulance or helicopter. Your level 3 trauma center are your very little community places like the Melrose Wakefield, places where initial emphasis is placed on stabilizing this patient and making them okay to be transferred to a level 1 trauma center. So level 3 trauma centers are your community hospitals where their job is to make sure that this patient stays alive until they get to Boston. And level 4 is make-believe.
Make believe.
So here is our absolute 100% things that we must do for a trauma patient. So first and foremost, scene safety for you, your partner, your patient, absolutely. If you need any additional resources, ask for them early. Our primary assessment, where we identify primary problems and fix them, is really the only actual fixing of anything we're going to do on scene. Problems with airway, breathing, and circulation are direct threats to life. If your patient has a problem with airway, breathing, or circulation, you fix that problem the moment that you find it, and then you move on. We want to make sure that we provide cervical spine stabilization for the patient. So manual control at first, and then a collar, and then we'll get into backboarding and all of that stuff. But maintaining a patent airway and ensuring adequate oxygenation for your patient, either with a non-rebreather mask or positive pressure ventilations with a BVM, and controlling any hemorrhage and treating for shock, that is it. Everything else, this rapid trauma assessment we're going to talk about here in just a few minutes, is we're going to find things very quickly and then we're going to fix them in the ambulance. If you didn't find a problem during your primary assessment and it was a primary issue, not only is that going to be grounds for you to have to repeat the station, that is also, as far as when we talk about actual sick people, finding a problem during your primary assessment or missing a problem during your primary assessment and not fixing it creates dead bodies. And that's all there is for our introduction to trauma. Anybody have any questions? Comments, concerns? All
I
right.
actually wanted to ask you, so I got an email that says the password has been changed to my Cataldo ambulance service.
I got that email too.
So is this for your punch clock or?
I'm not sure, just hi Alyssa, your account password for Cataldo ambulance incorporation has been changed. If you do not make this change, please contact your administrator immediately. And it's a no reply.
I'm gonna put you guys on hold here for a couple minutes and I'm gonna go ask somebody.
Thank you.
Yep. I'm just waiting for chapter 9, part 5 to come. Maybe it'll come up.
like they're gonna do real good in Disney. But okay. There was a book of my life. This would totally 1000% be the fucking title. So it was a dark.
All right, everybody, listen up. I got IT here. They're going to chat with you guys for a minute to try and figure out what it is that you're receiving. So listen up.
Hey, so what exactly is going on? Hello?
Some of us got emails saying that your account password for Cataldo has been changed. If you did not make this change, please contact us please contact the administrator immediately. And it's from like no reply SAASHR.
HR, just at hr.com.
Yeah, like the email is just no reply at SAASHR.com.
Okay, but have any of you tried to sign in since you got that? Like sign out and sign back in?
No, but I don't know like what it's for signing into. Like if it's for the time clock or the Chronos thing. Or...
So if it's not specifying anything, then that definitely sounds like spam that you should not click on. Because as far as I know, there have been no mass resets of any kind of passwords. I haven't sent anything out. My boss hasn't. So I would definitely not click that.
Okay, there's no link to click though. It just alerts us that our password has been changed.
Really? Okay. Could one of you forward that to me, if you wouldn't mind?
Yeah, what should I forward it to?
TKRUGH at Cataldo Ambulance.
Okay, I just sent it. Thank
All
you.
right. Thank you very much. Yeah. Just ignore that for now, and then if you find you're having trouble logging into anything, you can just let me know or let my boss know. We'll figure it out. But for now, I would just ignore it.
Sounds good. Thanks so much.
No problem. Thanks for letting me know. Honestly, not entirely sure what it is. Sounds like spam, but it wasn't even a link to anything. So I told them to ignore that for now. I have them forward it to me, and if they have any issues, contact me about this. So thank you, sir. I will try to figure out what the hell it was, I guess.
Okay. Jessica, I see your message in the chat room there about not being able to get into Tavuti. We'll take a look at that when you get here today, okay?
Word, I can hear you. Thank you.
All right, so we've talked about a brief introduction to the ways that people get injured. Now we're going to talk about our secondary assessment of our trauma patient. We skipped over the scene size up. We skipped over the primary assessment. We have already beaten that. At this point, you know that it starts with the scene size up. You start evaluating the scene the minute your ambulance pulls up and you start figuring out what you have, what you need. Is this a safe spot for me to be in? Your primary assessment doesn't really change a whole lot. You're still going to start forming your general impression. You're still going to be looking for life-ending exsanguination. You are looking for gross hemorrhage, especially in a trauma patient. From there, you're getting your level of consciousness. You're assessing and treating problems with airway, breathing, and circulation. All of your patients are going to get oxygen, 15 liters per minute by non-rebreather mask. You're going to monitor and treat aggressively for signs and symptoms of shock. And now we need to talk about getting into the actual assessing of this patient's traumatic injuries. Our secondary assessment still doesn't change a whole bunch. We're going to be getting a focused history. We don't really need to know about, an illness or an injury they had 10, 15, 20 years prior. We want to know anything that's going on with them that can be relative to what happened to them today. We do a physical examination. If our patient doesn't have a significant mechanism of injury, if our patient is not expected to be very, very injured, like those multi-system trauma patients. So we'll go right back to our single simple laceration, broken wrist, broken forearm, something like that. We are going to focus on areas that are painful to them or that their mechanism of injury dictates us to look at. So anything that hurts and anything that's connected. Your patient's chief complaint in a trauma patient is generally pretty simple, especially if it's not a significantly injured trauma patient that's really not so reliable or maybe not talking to you at all. Why is getting the patient's chief complaint very simple with most trauma patients?
You can usually see it, whether it's like bleeding, a broken limb.
Perfect. Or they're going to tell you all about it. Holy crap, I missed a step and I heard this explosion when my foot hit the ground and now my ankle's pointed left and right instead of front and back. Okay, well, there we go. Now you have it. That's the chief complaint. History of the present illness for this is, how did it happen? All good stories, especially traumas, start with hold my beer, watch this. And getting down to the nitty gritty of how did you actually do this is going to help us get into some of the rest of our examination. Because how they were injured, how they fell, how they broke that bone is going to tell us the direction and strength of the force that was applied to them, how it actually made contact with their human. Did they have any protective equipment in use? People, who ride bikes should wear helmets. People that skateboard and rollerblade generally should consider all of the things that can hit the ground when we talk about trauma. And protective equipment is going to stop you or at least slow down the amount of widespread trauma that you will inflict on your person. Realistically, when we get down to brass tacks, what we are really looking for is areas that the patient tells you are painful resulting from the incident. And we do our physical examination from there. We're going to tailor this physical exam of the non-significant mechanism of injury patient to injuries that hurt and involve the chief complaint, or injuries where our index of suspicion from their mechanism of injury tell us they should have other problems. We inspect. The first thing we're going to do is look at, does it look symmetrical? Does it look anatomical? Does it look like something's out of place? Is there, a bend in this patient's tibia and fibia where there's no joint? Okay, well, that tells me we have a problem, because long bones are only supposed to bend where they have a joint. If you have a tib-fib fracture and there's a bone sort of no longer continuity, guess what? It's going to bend somewhere that it shouldn't. But I wouldn't want to just jump right in to poking and prodding and touching that. Because like what we talked about with assessing an abdominal pain patient, palpation's gonna hurt. So we inspect first, we look at it. Does it look the way a limb or a person is supposed to look? We are looking for changes in symmetry, changes in color, changes in shape, or changes in my patient's ability to move that portion of their body. There's my inspection. When I palpate something that I think might be broken or might be injured, palpation is going to tell me a bit about abnormal shape, abnormal texture. If you were to palpate your own lower extremities right now, they'd feel intact and solid. When those bones are broken, oftentimes when we do our palpation, they feel kind of mushy because there's no longer that continuity. Your bones are the scaffolding that holds this whole structure we call a body up. When those bones are broken, the scaffolding and the holding up of really doesn't happen anymore, and it is kind of a mushy feeling. Temperature, that's going to tell me about perfusion distal to this injury. If my patient has a change in body temperature in their foot, let's say we're talking a broken tib fib right now, we're talking broken lower portion of the lower extremity, and the foot and ankle distal from where that injury occurred are cold. What does that tell me?
There's no circulating over to there, so something's up.
There's no circulating blood flow over to there. Same thing as if there's no sensation, that tells me that there is no actual nerve messages getting passed, and there may be a neurological injury. When we are palpating and examining our patient's extremities, we are going to always check all 4 extremities for circulation, sensation, and motor function. And those things are going to tell me, is the circulatory system intact? Is the neurological system intact? And I can check almost all 3 of them all at once. If we're speaking about chest injuries, we're going to listen for decreased or absent breath sounds. There's a couple of injuries for your exam that involve your patient's chest that you are supposed to find them during your primary assessment. You are supposed to fix them during your primary assessment. And remembering to listen to lung sounds and expose your patient's chest is going to tell you almost right away that your patient has one of these 2 injuries. It's really, really simple as far as trauma goes. What actually are we looking for? What actually are we palpating for? Well, here's your list. When we evaluate a trauma patient, we are looking for that top little bit right there, DCAP BTLS. Get used to saying this, know what these mean. Deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling.
I have a question on this, right? So if we were to say that, like, that's what we're doing, like, we're just like, oh, I'm going through DCAP BTLS on the physical exam, is that a no?
No, you can do it, but you better know what it means because they'll ask you.
All right.
So when we get into assessing our trauma patients, the stuff we're going to work on later on today and the stuff that we'll talk about through the rest of the lecture, right? In the classroom and in your exam, the first couple times you say DCAP BTLS, if you rattle off deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling, and then you move down to the next body part and you look for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling, and then you move down to the next body part and you start that, I am already tired of hearing you say those words. So the next thing I'm going to say to you is, all right, I understand you know what that means. Just continue. I'll stop you if you find something. But keep saying it until somebody tells you not to. So what is a deformity? We talked about that briefly. A deformity is a bone, an extremity or a bone that does not look the way that it is meant to. If we take a look at this patient's arm, right about here, Does that look like what an arm's supposed to look like? You don't need to be a radiologist to know that there is something wrong here, right? As far as the National Registry is concerned, anytime we see a bone that is obviously broken, we are going to call that a painful, swollen, and deformed area, because we don't have the X-ray technology to be able to diagnose it in the field. So even if there is bone ends poking out through this patient's skin, it is painful, swollen, and deformed. What do you guys think a contusion is?
It's a bruise.
Yeah, it's just a real nasty one. A contusion is a bruise. What about an abrasion?
Like
A
a minor
scratch.
cut.
Yeah, scratch, minor cut. Think of like a road rash or rug burn. That's an abrasion. It breaks the integrity of the skin, but it doesn't really get down to the structure. It kind of just scuffs off the top layers. It gets some capillary bleeding, a little bit of leaking, nothing too particularly crazy, and it is intensely painful for your patient. So something like road rash from crashing a motorcycle, that is, the pavement is actually abrading away all the tissue that it comes into contact with. It's like being sanded. And it's likely to hurt a lot. It's likely to cause some bleeding, but it's not likely to be life-threatening. Punctures and penetrations, also pretty straightforward. Anything that is used to make a hole in the body is going to be a puncture or a penetration. What about burns? What do you think burns typically look like? Nobody knows what a burn looks like? Anybody spend too much time
Yeah.
outside this weekend?
A burn can look, it could be bubbly, it could be red. It depends what kind of degree the burn is. 1st degree, 3rd degree, 2nd degree.
It can be red, angry looking skin. It could be blistered skin. It could be black, charred, kind of gross, almost like used charcoal looking. Not good.
I wanted to let you know,
Yep.
I've been kicked out of this class, like, since yesterday. It's been on and off getting kicked out. I just got kicked out again.
How'd you get kicked out of go to training yesterday?
I don't know. It's just, it freezes and then it completely exits me out of the class.
All right, well, it's being recorded.
Okay.
Swelling, this is a pretty good indication of what swelling looks like. I don't imagine that this gentleman was born with that great big goose egg on his forehead. When tissues are injured, when cells are injured, they leak. And in their leaking, the tissue begins to get larger and spread out and larger and spread out. It is normally pretty intensely painful when we palpate this, because we will touch it. Don't expect a Christmas card from your patient, because all of this stuff, when we're evaluating a trauma patient, is likely to some degree to cause an increase in their amount of pain. But it's all done for a reason. At the end of our secondary assessment, we're still talking non-significant mechanism of injury. Our patient's conscious and alert and speaking to us. We're going to get some baseline vital signs. We're going to get their past medical history. So our sample questions. Why do you think I asked this patient some sample questions?
You want to make sure that he's not on any medications. You want to make, you want some history on what's going on
Yeah.
besides the mechanism of injury.
Yep. I asked those sample questions because I want to know how likely is this patient's body to put up with all of this. If they may be like this fella right here, who may need to go have some internal hardware placed in that arm, he's going to need a surgeon. Surgeon's gonna need to put them out. They're gonna need to do more advanced things in the hospital possibly. Same with this patient. Hell, maybe even the same with this patient. He could need a plate. So getting a good medical history is going to tell the next level of provider that I'm eventually going to hand this patient off to some of the initial things that they need to know about this person. When I'm looking at their signs, I'm looking for things that I can hear, see, smell, feel. Their vital signs are objective. Sweaty skin, changes in their ability to move, vomiting. Those are all things that I am physically witnessing and can quantify. My symptoms, the subjective stuff, patient's going to tell me about it. Pain I can't see. Dizziness I can't see. Nausea I can't see. We're going to work on this today in class during the lab, sizing and appropriately applying a cervical collar, especially for our significantly injured trauma patients. This is going to be a big deal. If they can still move all of their extremities and they're still getting neurological messages from their brain out to the rest of their body, I don't want to be the one responsible for causing something that makes that no longer happen. So we want to make sure we take care of their cervical spine. But now let's talk about someone who is significantly injured. What do we think's going on here? Why did they say this patient's significantly injured?
He's still in the car, needs to be treated in the car.
Let's look at the portion of him that objectively we can see is definitely injured.
Yes.
He has a head injury.
He's got a head injury, right? Most fatals involve a head injury. This patient obviously has a head injury. You know, maybe he's altered, maybe he's not. But if his head went forward hard enough to cause that kind of bruise right away, other pieces of him also have to be injured. It is almost categorically impossible that he hit just his face that hard without actually striking something else. Right away, just by definition, with a quick look at this, I can tell you that if he only has that isolated head injury, he should buy a lottery ticket on his way home from the emergency room. Our secondary assessment of a significantly injured trauma patient is fast, down and dirty. Really only takes, probably I could have you guys doing it in a minute or two tops. Because at this point, we're looking for secondary injuries, secondary problems. Am I wasting time fixing those kneeling in the gutter?
No.
No, I'm fixing those in the ambulance because I'm going to have time to kill between scooping this patient up, putting them in the ambulance, and driving them to the emergency room. Our rapid secondary assessment of a trauma patient should absolutely be done on scene, but it shouldn't take long. It shouldn't be something that takes us forever and we get all hung up and lost in the weeds. This is going to direct my care of this patient in the ambulance once we get going. Now, this is done in head to toe fashion. Why do you think we do this as a head to toe assessment?
The height's the most important, and then like going down from importance.
Going down from importance, and
so you don't miss anything.
Yeah, exactly. If I start at the top and I work through each and every single one of these things, inspect, palpate, auscultate, inspect, palpate, auscultate, inspect, palpate, auscultate, inspect, palpate, auscultate, looking for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. And then I roll the patient to put them on a backboard, and I do the same thing from head to toe along the patient's posterior. Is it even possible for me to miss something?
Hopefully not.
No, because I started at the top, I worked my way to the bottom, I rolled the patient, and I started at the top, and I worked my way to the bottom. I have physically touched, poked, prodded, and looked at every single spot on this person. And now we can leave. We can get our baseline vital signs either on our way to the ambulance or in the ambulance. We've already obtained some of them during our airway breathing and circulation. We have done all of the important things. We have found all of the everything that we are going to find, and we get to moving on. Because if we waste this patient's time, we waste the surgeon's time, and we are stealing minutes from this patient's life. Our trauma patient, sure, we're going to communicate with them if we're able to. I'll tell you, for your examination purposes, your trauma patient will be unresponsive. Your medical patient will be speaking to you. Your trauma patient, in the very beginning, as you're approaching the patient and having your partner maintain C-spine stabilization, and you're checking for gross hemorrhage, and you're assessing and treating problems with airway breathing and circulation, tell me that you're going to expose this patient. A trauma patient with a significant mechanism of injury should have all of their clothing cut off. Why?
So you can see if there's anything else that's wrong or any deformities just because of DCAP BTLS.
Yeah, it's very difficult for me to inspect and look at anything if it's covered in clothing. So we will cut right through everything, cut their clothing right off, so I can actually get a visualization of what this patient looks like. Now, when we talk about things like contusions and we talk about bruising, generally speaking, it takes a little bit of time for a bruise to form. Generally speaking, blood has to leak into the tissue and then degrade and break down, and it changes color and you get that nasty looking bruise. Depending on how much blood and how big of a laceration they have on the inside, leaking all that blood, we may start to see the beginnings of a bruise. We may see some discoloration or some purpling of the skin. That's a big deal, because that means there's a significant leak happening inside this patient. And all of that blood that should be remaining inside this patient's vascular structure and providing for perfusion is now leaking. So on top of being injured, they are hypoperfused. And hypoperfusion is the body marching its merry way right on to no longer being of existence. And that's why we expose our patient. If we have a significantly injured trauma patient, multi-trauma, significant mechanism of injury, always assume that they have some sort of spinal injury, spinal compromise. The only time that we stop or alter our assessment for a trauma patient is if we need to address something that is an immediate life threat. So let's say your patient, for argument's sake, had a patent airway and you were managing his airway with had an airway that wasn't patent, excuse me, and you were managing it with a jaw thrust, and your partner had no PA in, and the patient was breathing 14 times a minute, adequate depth, so you put a non-rebreather on them. If they went into respiratory arrest and stopped breathing altogether, would you finish your assessment, or would you go back and fix the respiratory arrest?
Arrest.
Respiratory arrest.
Yeah, because that's a primary problem. All of the things we're going to find, all of this DCAP BTLS, all of that is utter nonsense compared to the fact that your patient just quit breathing. Because even if I find this stuff, I can't do anything about it. The only thing I can do is make them no longer be in respiratory arrest and start to ventilate them with positive pressure ventilations and a BVM, one breath every 5 or 6 seconds. There are certain spots on the body we are going to look for things in addition to deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. When we look at the head, there's a test we can actually do to confirm a basilar skull fracture. It's called the halo test. You take a 4x4 piece of gauze and you fold it into triangles, fold it in half, then fold it in half again, and you dunk it in the fluid that's coming out of your patient's ears or nose. Then you set it aside to dry. You'll see if the patient is leaking cerebrospinal fluid, there'll be this sort of golden halo type ring on that gauze. That is 100% an indication that your patient has a skull fracture. We don't have to be able to prove it, but it indicates to me that it's likely. If your
Yep.
patient has unequal pupils, so when we're assessing the head, we're going to check and make sure that those pupils are equal round and reactive to light. We're going to look for jugular vein distension. When we talked heart failure last week, we were talking about how blood backs up to where it comes from. If we see jugular vein distension, that means blood is having a difficult time getting back to the heart, and it's backing up into those jugular veins, and we will see these great big engorged jugular veins. Those are a telltale sign that your patient is in obstructive shock, that your patient has a tension pneumothorax, and the vena cavas have both been pinched off by increased pressure inside your patient's chest, and that they're going to die if something doesn't go their way in the very near future. When we're assessing the chest, we're going to look for, this is probably one of the most important words that you can learn, paradoxical motion. Paradoxical motion means that the chest is asymmetrical. When the patient takes a breath and expands their chest wall out, one whole section of their rib cage is actually going to suck in instead of going out. And then when they exhale and shrink down the size of their chest wall, that same section of their chest wall is going to poke out. That's what's known as a flail segment. That is 2 or more ribs broken in 2 or more places, and it is the hallmark sign right here, paradoxical motion. We can fix that. Crepitation, that's that grinding and grating of bone ends. Distension, that's telling me that we have buildup of pressure. Equal breath sounds is going to tell me whether I'm dealing with a pneumo or a tension pneumo. We do a whole lecture on chest wall injuries, but these are the things that we need to be on the lookout for. They tell me very, very detailed problems and very, very easy solutions for them. And most of this, if we expose our patient and do our primary assessment right, when do we find this?
Primary assessment?
Yeah, during the breathing assessment of our primary assessment. I'm going to expose my patient and I'm going to see that paradoxical motion. I'm going to hear those unequal breath sounds. I may see bubbling, frothy blood coming from a hole in my patient's chest. And I know right then and there that that's a problem with the mechanics of breathing. It is a primary issue, and I need to go about the business of getting that fixed. When we inspect our patient's pelvis, we're going to be looking for priapism in males and traumatic vaginal bleeding in females. Priapism in a male is a sort of another hallmark sign for a neurological injury. Spinal cord injuries oftentimes will cause your male patient to get this painful erection at an obviously strange time that just won't go away. If they've been exposed to a significant trauma and you're thinking a neurological problem and they have a priapism, 2 plus 2 is 4, and they probably have some sort of spinal injury. As we move down the body and we get to the extremities, we're going to check for distal circulation, sensation, and motor function. Do they have a pulse? Can you feel me touching you? Which finger am I touching? Which toe am I touching? Wiggle your fingers for me. Wiggle your toes for me. It's going to tell me whether they still have circulatory and neurologic function distal now, further away.
If they're unconscious, they can't tell you that.
Oh, but there's things that I can do. We're gonna
Okay.
talk all about it. There's all
Can you do
sorts of
like
tricks.
Can't you do like a knee tap to see if they have like a reflex? Does that have anything to do?
So same vein, but different test. What we'll be checking for with our patients is what's called a Babinski reflex. If I take my scissors on an unresponsive trauma patient
That's the
and
one
run
on
them
the
up
foot.
along the bottom of their foot, their toes are gonna flex and then fan back out. That tells me that they have sensation. They'll be completely unresponsive, but their toes just naturally do that when I introduce some stimulation down there. All right, everybody, that was it. We're gonna do most of the learning as far as how to assess a trauma patient in the lab when we get in this afternoon. Anybody got any questions?
I'm gonna be honest, I missed the first part of this. Did you address the problem